Welcome to This Explainer. When you first put a stethoscope to a patient's chest, you hear that incredibly familiar, reassuring rhythm, right? Lub-dub, lub-dub. But what if I told you that the very first sound you hear, that classic lub, isn't just a simple static noise? It's actually a secret Morse code. Seriously, it's a highly dynamic acoustic signal detailing the exact mechanical health and physical forces happening inside the human heart in real time. Today, we're going to decode that signal together. Okay, let's dive into this. Have you ever actually wondered what physical forces control how loud or soft a heartbeat sounds through your stethoscope? Why does it absolutely boom in one patient and barely whisper in another? Well, it's not random. It's pure physics and fluid dynamics. And by the end of this explainer, you'll know exactly how to read those acoustic clues like a pro. So, here's our quick roadmap for today. First, we'll cover the anatomy of the lub. Second, we'll look at the 4 dials of intensity. Third, decoding abnormal heart rhythms. And finally, when S1 splits in 2. Let's get right to it. Section 1. Anatomy of the lub, or the foundation of the first heart sound. Before we can understand why the volume changes, we really have to understand the noise itself. First heart sound, or S1, is our primary clinical marker for the onset of ventricular systole. But it's not the sound of blood flowing. Actually, scratch that. It's more like a slamming door. When the ventricles squeeze, the pressure inside them rises incredibly fast. The precise millisecond that ventricular pressure exceeds atrial pressure, the atrioventricular valves are violently pushed shut. S1 is the high-frequency sound produced by the sudden tensing of those valve leaflets and the surrounding structures. But here is where it gets really fascinating. That single sound you're hearing, it's actually 2 completely separate doors slamming. S1 consists of M1, the closure of the mitral valve on the left side of the heart, and T1, the closure of the tricuspid valve on the right side. Consider this number, 20. Under normal healthy conditions, the mitral and tricuspid valves close less than 20 milliseconds apart. That is just unbelievably fast. It's way too brief for the human ear to distinguish them as separate events, which is exactly why we perceive it as one crisp, unified lub. Section 2. The 4 dials of intensity, turning up or down the volume. Now, what's really interesting about this slide is how it breaks down the exact mechanics of what we hear. So we know what makes the sound, but what actually controls the volume knob? There are exactly 4 variables that dictate the intensity of the S1 sound we hear: valve integrity and mobility, velocity of contraction, the timing of closure, and transmission through the body. If you can understand these 4 dials, you can literally diagnose what's happening mechanically inside the heart just by listening to the volume of S1. Let's break these down one by one, shall we? Dial number 1 is valve integrity. Let's go back to our door analogy. In mitral stenosis, the valves remain wide apart at the end of diastole. Imagine leaving a heavy door wide open. When a strong wind catches it, it travels a long distance and slams shut with a massive, loud bang. That's exactly why mitral stenosis causes a really loud S1. On the flip side, look at mitral regurgitation. Here, the leaflets might be incompetent, calcified, and mostly immobile. It's kind of like a broken, jammed door. When the pressure hits it, it barely moves, giving you a very soft, quiet S1. Dial number 2 is timing, specifically the PR interval. When a patient has a short PR interval, like in tachycardia, man, everything is happening so fast, the valves are caught wide open when systole suddenly hits, resulting in a loud, aggressive snap. But when a patient has a long PR interval, maybe they have bradycardia, the heart is really taking its time. That long pause allows those valve leaflets to just gently float closer together before they actually close. So when they finally do meet, they just produce a quiet, soft sound. Our third dial is the velocity of contraction, also known as dP/dt. This is all about the rate at which pressure rises in the ventricle. It dictates the snap of the closure. If a patient is in a high output state, say they're exercising, they have a fever, or they're tachycardic, the heart is contracting with immense force and speed. That high contractility leads to a super loud S1. Conversely, if there's poor myocardial contractility, the pressure rises sluggishly, and that results in a soft S1. Finally, dial number 4 is transmission. This one is purely physical. Because we're listening from the outside, the physical barriers between the heart and our stethoscope totally matter. A thin chest wall is going to amplify the sound, making S1 seem loud. However, physical factors like obesity, emphysema, which hyperinflates the lungs, or a pericardial effusion, which is fluid around the heart, will act as insulation. They dampen the sound, creating a soft S1. Section 3, Decoding Abnormal Heart Rhythms. What pathological variations actually tell us? Let's apply those four mechanical rules to chaotic, real-world clinical practice. So the crucial point is that when the heart rhythm is abnormal, S1 intensity changes in very predictable ways. In conditions like atrial fibrillation or flutter, the cycle lengths are constantly changing beat to beat, right? Which means the force of ventricular contraction varies wildly. Consequently, the intensity of S1 will be completely variable. Now, if you specifically hear a loud T1 component, it points to conditions increasing tricuspid flow, like tricuspid stenosis or an atrial septal defect. You also have to watch out for confusing lookalikes. Aortic ejection clicks, which are just the semilunar valve's opening, happen incredibly close to S1 in the cardiac cycle and are frequently misidentified as a loud S1. And then, oh man, we have the absolute drama of the Canon S1. This is an intermittent, explosive sound. It happens during complete heart block or ventricular tachycardia with AV dissociation. So what's happening mechanically? The atria and ventricles have completely disconnected. They are literally beating to their own drums. Occasionally, just by pure chance, the ventricles will violently contract at the exact moment the atria have pushed the AV valves to a wide-open position. The resulting slam is massive. It's this sudden, booming heartbeat amidst otherwise quiet sounds. No way you'll miss it.
Section 4, when S1 splits in two, breaking the single sound.
We know M1 and T1 normally close within 20 milliseconds of each other, but pathological delays can rip that single lub into two entirely distinct beats. And this brilliantly illustrates the difference between a wide split and a reverse split. A wide split S1 occurs when there's an increased delay between the mitral and tricuspid closures. For instance, a right bundle branch block causes an electrical delay on the right side of the heart, pushing T1 to close noticeably late. But then we have the incredibly rare reverse split S1. This is where T1 actually fires before M1. This happens in conditions that severely delay mitral closure on the left side. Think left bundle branch block, severe mitral stenosis, or even a left atrial myxoma physically getting in the way.
There's also a fascinating mechanical exception that creates a wide split. It's a congenital defect known as Ebstein anomaly. The malformed tricuspid valve produces a highly distinct mechanical wide split. Because of the sheer size and delayed movement of the abnormal tricuspid leaflet, it creates a loud, delayed T1 that clinicians often refer to as a sail sound, like a ship's sail catching a heavy gust of wind. Which brings us to the core takeaway of our explainer today. As the clinical literature emphasizes, the intensity of S1 is highly variable and provides significant diagnostic clues. A stethoscope is not just an audio speaker. It's a direct window into the exact physics, pressures, and fluid dynamics of the human heart. The volume of the heartbeat tells a rich mechanical story if you know how to listen.
So I want to leave you with this final, provocative thought. The next time you place your stethoscope on a patient's chest and listen to that rhythm, are you just going to hear a simple sound? Or will you visualize the slamming doors, the floating leaflets, and the shifting pressures of cardiac mechanics to truly decode what the heart is telling you? Thanks so much for joining me on this explainer, and keep listening closely.